Good evening, dear friends. I wish you a very happy 2023, a happy, healthy, and peaceful new year to all of you. Last year, I started lecture series 2022 on January 1st on the request of my postgraduates from Manipal. And this year, I am starting lecture series 2023 exactly after 1 year on January 1st on the request of thousands of postgraduates all over India. Somebody asked me why on first. Can we have just a free time on first? But no, anything you start on the new year day is going to continue. So with that thought, I thought I must start on January 1st. I should not be complacent. Yes, we had a celebration last night. Today it's time to come back to academics. Why this topic? This is a bread and butter for obstetrician, Caesarean section. Hundreds of techniques have been evolved, and each one has its advantages and disadvantages. And then in the exam, this is a sure question for most of the postgraduates. Critically analyze the different techniques of Caesarean section. I have given this talk in progress, which is conducted by Dr. Geeta Arjun long back. And this time I have one more talk in ASCOG Kolkata, exactly based on this. So I have updated myself. The references are as recent as 2022. You may be wondering if I'm giving the talk in ASCOG, why I'm giving today. ASCOG, I have got only 15-minute slot. I'll be talking only excerpts, but today and tomorrow, maybe in day after tomorrow also, if the topic is not over, because lots and lots of things to be discussed in this. So I will go slowly one by one, because this is very useful to postgraduates. This is very useful to practicing obstetricians. This is very useful to everyone. That's why I want to go very slowly and discuss each and every small technical change, whether there is evidence, whether we should continue with those techniques, whether we should discard them, or whether we can go back to our own techniques. Before I go further, I would like to put a disclaimer like in the movies. Some of the techniques explained may not be speaker's choice. That is not my choice. However, all techniques mentioned and discussed are evidence-based. In the end, I'm definitely going to summarize all the evidence-based techniques, and on the other column, I'm going to give you what is my take on each of those techniques. You may have to wait till the end of the talk. The listener is advised to analyze and adopt the technique that he or she feels is the best, or continue with the technique that has served him or her well in the past. Many of us feel that the technique that I have been using has served me well, so why should I change now? Yes, I totally respect the experience of the senior people and the enthusiasm of the juniors to adopt new techniques. So the talk is placed exactly for that reason. Well, the technique is quite simple. Take a big chop off and the abdomen is cut open and the baby is delivered. All of you must be knowing why the name Caesarean section came. It's Lex Caesarica. In the first time, they had to deliver a dead baby from a dead mother in order to bury them separately. And the permission was granted by Caesar under the code, Caesarean code. But subsequently, they developed the technique to cut open the abdomen of a live mother and deliver a live baby. But invariably, mother used to die either because of infection or because of hemorrhage. Slowly, over the period of time, they developed the technique of controlling the hemorrhage, controlling the infection, and now the complications of Caesarean sections are less than 2%. The basic steps of Caesarean section, any undergraduate would answer. Number 1, open the abdominal wall in layers. Number 2, open the peritoneum, both visceral and parietal. Open the anterior uterine wall, deliver the baby, deliver the placenta, close the uterine wall, close the abdominal wall in layers, which includes peritoneum. So I would go with each of these steps, different techniques used in each of these steps, critically analyze them, and I will also give you evidence for them and my take probably. Let's talk about the opening of the abdominal wall first. Whether it is Caesarean section or any surgery, we have to open the abdominal wall, and there are different techniques of opening the abdominal wall. And surgeons feel they have mastered the art. However, obstetricians also have mastered the art in a different way. Vertical incision has been the practice in the olden days. In fact, when I was a postgraduate, most of the cesareans were done with a vertical incision. Over the period of time, we have realized vertical is not required. Midline was the favorite again because it's the least vascular area and minimal bleeding during the surgery. But that exactly will be the problem. The healing will be poor and the incisional hernia will be very high. Paramedian incision is supposed to be stronger, but nowadays nobody does paramedian incision, including the surgeon. So I have just grayed it out. Then comes the transverse incision. As I was telling, obstetricians have mastered this transverse incision because it is cosmetically appealing to the women. And after all, we are going to deliver the babies from the lower segment, and better we put the incision at that corresponding area. Again, there are different methods in this transverse. Fan and steel has been the time immemorial, let's say from 19,000. Joel Cohen in 1977, they developed a technique. I'm going to talk in detail about them, so I'm not going to spend time now. As you can see here, Joel Cohen is slightly higher than the fan and steel, but it is still a lower transverse. Maillard's incision is a muscle cutting incision when you don't have enough exposure or if there is any difficulty to approach the uterus because of the adhesions and things like that. You may use a muscle cutting incision, but that is usually not done in Caesarean section. Cherny's is another muscle cutting incision, maybe slightly higher level than the Maillard's incision. Joel Cohen incision has been slightly modified and they have used in Misgav Ladakh Hospital in Israel, and that has been popularly now called Misgav Ladakh technique. As I said, this incision is 3 centimeters below the line joining anterior iliac spine, but higher than the fan and steel incision, what is given in the red box. The sharp dissection is minimized. That is the Misgav Ladakh modification of this incision. So at all levels, only the skin will be with a sharp scalpel, but after that, subcutaneous tissue and even maybe the sheaths and the muscle also all are separated with the help of the finger dissection. So division of the subcutaneous tissue, extension of rectus sheath incision. Of course, initial rectus sheath will be incised with the scalpel, but then it is just torn apart like that with the fingers. Separation of rectus belly also is not with the sharp dissection. It is just separated with the finger dissection. So that is the Misgav Ladakh technique. The advantages and disadvantages I'll come little later. It will be obviously very fast and minimal hurting of the vessels or incising of the vessels. So that's why the bleeding also would be little lesser. Then single layer closure of an exteriorized uterus. I am going to talk about each and every one of them, whether single layer is better, double layer is better, exteriorization of uterus is better, or internalization of uterus is better. All those things I'm going to talk, but Mizgav-Ladakh is essentially a slightly higher transverse incision than fan and steel, and then all blunt dissections and single layer closure in exteriorized uterus. Then non-closure of the peritoneum. Surgeons always tell us that there is no need to close the peritoneum, whether it is visceral or peritoneal, parietal, because peritoneal will find its partner and they will come closer and they will. In fact, if you unnecessarily suture the peritoneum tightly, there can be avascularity and there may not be proper healing. So anyway, I will discuss that also. Now let us look at the advantages and disadvantages of vertical versus transverse. This is very, very obvious. This is basic undergraduate. In vertical incision, obviously you need less dissection and that's why less skill is required. You just put a midline incision, not many structures you come across. Whereas in a transverse incision, after the subcut, you have to incise the rectus sheath. You have to separate the rectus sheath from the rectus muscle first, and then you have to separate the rectus belly, and all those dissections are more. That's why the bleeding also will be more, especially on the lateral sides. You will be coming across the inferior, the vessels. Less blood loss in the vertical because in the midline, as I said earlier, there's hardly any blood supply because all are almost like end arteries in the abdominal wall, whereas there is more blood loss in the transverse incision. You have a good exposure. That's exactly why, if you recall, in the ovarian malignancy, we go for a midline incision. In fact, midline subumbilical, we can extend into the umbilical also. It's a good exposure, especially if you want to, tackle the placenta previa, placenta accreta, percreta variety with a Caesarean hysterectomy. Probably midline incision would be better because it's a big uterus compared to a gynecological uterus, which can be managed with a fan and steel uterus. Then obviously in transverse incision, there is inadequate exposure, but most of us have now developed the art of delivering the normal situation, delivering the babies with a transverse incision. That's not a big deal at all for us. Easier to extend, yes. Suppose there is a bigger baby, twins, or sometimes you may have to extend the incision. It's always easier to extend the midline incision upwards, right? Whereas the transverse incision, you cannot go all along into the flanks. So it is very difficult to extend the transverse incision. More postoperative pain in the vertical incision because it goes across the dermatomes. So many dermatomes it has to cross through, whereas in the transverse incision, it is only one dermatome. So postoperative pain is less. Poor healing. This I have probably telling the third time. In the midline, the vasculature is less. That is advantage during the surgery because blood loss will be less. But after the surgery, for healing, it is not at all good. So in the vertical incision, chance of incisional hernia is more, whereas the bleeding is more during surgery in a transverse incision, but that's exactly why the healing is also better because of good blood supply there, and chance of incisional hernia is less. That's why probably we are now preferring transverse incision. But mostly for all women, suprapubic transverse incision is cosmetically more appealing than a vertical incision, which comes up to umbilicus or maybe beyond the umbilicus. So what does evidence say? I have just now told you the advantages, disadvantages, critical analysis. In fact, I want to tell the postgraduates now, whenever a question comes, critically analyze. There are many questions like that. Critically analyze different techniques of cesarean, critically analyze different methods of hysterectomy, that is abdominal hysterectomy versus laparoscopic versus NDVH, critically analyze different methods of tubal ligation. Whatever question comes, what you have to say is what are the different methods available, what are the advantages and disadvantages, what are the different setup that you require, expertise, what are the post-operative problems, what are the hospital stay cost, everything. And finally, you have to talk about what does the evidence say about it. It's not just your opinion. It should be supported by the evidence. So here, as far as opening the abdomen with the different incisions, the evidence is very strong. So here, wherever I have come across, it is a Cochrane database evidence. And also it is supported recently in 2015 by PLOS ONE. PLOS ONE is one of the very high impact journals, as you all know. So as far as the abdominal incision, Joel Cohen Misgauladar technique have significant advantages in terms of reduction in operating and delivery time and blood loss. Obviously, because all the dissections are blunt dissections, that's why blood loss will be less, and they don't close the peritoneum and single layer closure, so operating time is also less. Post-operative analgesia is less because it's a transverse incision and not much of complications there. Post-operative morbidity is also less, 65% less, and hence the hospital stay. So they go by Misgauladar incision, but if we are not used to this technique, for example, I have never used this technique, I am quite comfortable with the fan and steel incision, which is also almost similar. And again, we also do not do lots of blunt, sharp dissections unless there are adhesions. We can go just blunt dissections and fast entry into the abdominal wall. Then comes the simple points, whether to use scalpel or electrocautery. Most of the postgraduates must have now seen, in surgeons especially, they use electrocautery everywhere. That has become a style. Even the rectus sheath is divided by electrocautery, muscle is divided by electrocautery, the fat is divided by electrocautery, everything is electrocautery. What is the evidence about these two? Again, it's a systematic reviews and meta-analysis that will say about this. I personally prefer incising with scalpel rather than an electrocautery device, unless maybe in gynecological surgeries, I use that. Here, we usually don't use any electrocautery instruments during Caesarean section. I'm sure most of the people are the same. We don't even use sometimes the plate that is needed for that. Only very, sometimes urgently, if we are following it up with hysterectomy, then we ask the assisting sister to put electroplate there. Otherwise, it's always scalpel in Caesarean section. Anyway, there is no clear evidence of superiority in short or long-term outcomes between the two. So we can use scalpel. There is no need to. In fact, electrocautery can be sometimes a little bit dangerous during Caesarean section because the baby is there. If you overshoot, sometimes that can be a problem. So we totally avoid it. And further, neither scalpel nor electrosurgery holds a clinically significant benefit. So why bother at all? It is not necessary to change to a fresh scalpel blade after opening the abdomen. This is some of the surgeons, they have a style. For the skin, they use one scalpel, and inside they use another scalpel. See, it is very superfluous. We are cleaning the abdomen so nicely with all the antiseptic, and we are also giving pre-operative antibiotics. So it doesn't really add to anything. So since the rate of wound infection is similar with one scalpel versus two scalpel techniques, there is no need to keep on changing the scalpel and things like that. I don't usually ask for a different scalpel for a skin and then for other things. So having opened the abdomen, now comes the question of parietal peritoneum and then the visceral peritoneum. In Caesarean section, as you know, after parietal peritoneum, we have to pick up the loose fold of peritoneum, the UV fold of peritoneum, what we call. That's the visceral peritoneum. And by incising that, we have to push the bladder down. So what does the evidence say? Before opening the peritoneum, can we do the Caesarean section? Yes, my former HOD, Dr. Kuntal Rao, was an expert in doing this extra peritoneal Caesarean section. That means after opening the skin, subcutaneous tissue, rectus sheath, and just separating the rectus muscles, you don't incise the peritoneum. You go as low as the symphysis pubis and strip out the peritoneum and then get the uterine wall. This is done especially if there is any infection in the uterus, chorioamnionitis and things like that. Because if you open the peritoneum and then enter into the uterus, the infection inside the uterus can get into the peritoneum and peritonitis will be there. So in such cases, you go extra peritoneal. That means you don't incise the peritoneum, you strip the peritoneum away from below and then look at the lower segment of the uterus. After all, you know, the peritoneum comes like this onto the bladder and then onto the uterus. So you just strip it away from the top of the bladder and then just get a space in the lower segment. So don't incise the peritoneum. So what does the evidence say about it? Extraperitoneal has the advantages in septic women in relation to serious maternal mortality and febrile morbidity. That's what I just now said. In cases of chorioamnionitis, we go for extraperitoneal section. Nowadays, not many people are well versed with this technique. Probably I have done one or maximum two extraperitoneal. This is also basically to demonstrate and see whether I can do it or not. We have not done it many times. Not many people are aware of this technique. It resulted in less intraoperative nausea and vomiting and less postoperative pain because you're not incising the peritoneum, and that's why it causes less intraoperative nausea and vomiting and postoperative pain. What about opening the peritoneum per se now? Using fingers to bluntly open the peritoneum to minimize the risk of inadvertent injury to the bowel, bladder, and other organs, as in Joel Cohen, is advantageous. Yes, that's what we do. We nowadays in Caesarean section, you should see. I should not say this, and it's not like you should be very fast. My standard dialogue goes, you should be very slow to be fast. I mean, it sounds very paradoxical. What I mean by that is you should go very meticulously, step by step, not in a rush way. And to your shock and surprise, you will be the fastest surgeon. Dr. Narayan Baliga was the anesthetist, and I was a very junior staff. My shortest, skin to skin, that too, it was a triplet. The first one was the singleton, and the second one was the conjoined twins. The entire cesarean has been, recorded. It was less than 15 minutes. But then, it is not the question whether you do it fast or slow. The question is whether you have least problems during cesarean section. And for that, you have to be meticulous, slow, go step by step. So when you do a blunt dissection of the peritoneum, it can be very easy. Peritoneum is very supple in all. In fact, during cesarean section, all these tissues are very well defined. That's the advantage. And in fact, in gynae surgeries, when you try to open the peritoneum, that opening the peritoneum itself will take 2-3 minutes sometimes. You don't know where exactly you have to. Here, because that enlarged uterus is there, all the bowels would have gone to the sides. And what is there right on the uterus is the peritoneum. And it is very easy to pick up that peritoneum and just make a nick. And after that, you don't have to go this way, that way. You just tear with the fingers. The only problem where you get is if there has been adhesions, if it's a previous cesarean section, there can be an adherent bladder may be pulled up, and there can be adherent bowels also, especially when the bladder is pulled up, you should not go for blunt dissection. You should go for always sharp dissection. Otherwise, you can tear the bladder base. So if there are adhesions, you have to go for the sharp dissection technique. It is better in the presence of dense adhesions, especially. Otherwise, a blunt dissection is better. There is so much of supporting evidence for that. So we have opened the parietal peritoneum. We have opened the UV fold of peritoneum and pushed the bladder down. Now we are ready to open the anterior uterine wall. So here again, there are different techniques or different methods. Types of uterine incisions, classical or inverted T. Classical is a deliberate one, whereas inverted T is not a deliberate one. You put a transverse incision and suddenly you realize that it's very difficult to get the baby out of that incision. Baby is bigger or your incision was smaller and you are so desperate and the baby is halfway in your position. Then you suddenly incise wherever you get hold in the desperate situation. So it will become an inverted T. So that's why I meant it is not a deliberate one. It becomes an inverted T. And believe me, inverted T is the worst type of incision. So nobody puts deliberately or intentionally inverted T incision. It is at the time of difficulty you go vertically after a transverse incision is made. Whereas a classical incision, though now 99.9% of the gynecologists do not know how to put a classical caesarean section incision, but it is coming back, especially in a case of, let's say, caesarean hysterectomy for a placenta percreta, wherein you don't want to go to the lower segment and disturb the placenta and things like that. Straight away go for upper segment, deliver the uterus. Anyway, this uterus is going to go away. You don't even have to suture properly the upper segment, just can put the towel clips and straight away go ahead with the hysterectomy. In fact, there is no need to remove the placenta also. That is what is told. In another lecture, I have told about that, talked about it. Then we have, of course, the lower transverse, that is the usual lower segment caesarean section. Lower vertical, I really do not know the actual advantage of lower vertical. It is claimed that lower vertical is specially used in a case of preterm baby, wherein you don't want to put a lot of stress on the baby, because in a transverse incision, the baby's head you have to, whereas vertical will be easier. And vertical is sometimes used when the lower segment is not very well formed. So you don't know where exactly put the transverse incision. So you go for lower vertical. But the problem with lower vertical is that it can always extend upwards into the upper segment and become like a classical, or worse is if it extends downwards and it will involve the bladder, it will tear the bladder. So I have hardly put lower vertical. I mean, it's only theoretically that we have missed. But J-shaped, yes, is always done, especially instead of making it a transverse incision into inverted T, you can go to one of the sides upwards. Usually we put not exactly transverse, we put slightly curvy, like a smiley. We put that way so that if you extend, it will go upwards. See, if you put a straight transverse and if you want to extend, especially with a sharp dissection, on the sides of the uterus, you know, the two uterine arteries are there. You will be cutting those arteries, and the bleeding will be so much with such dilated arteries. You will be in the pool of blood and you will faint before the patient collapses. So that's why it's always go little upwards, and then you can extend further on one of the sides and make it like a J-shaped incision. So these are the different types of incision, and there are methods of performing this incision also. So what do you mean by that? One is sharp uterine incision. As I said, you make a nick, of course. Usually I don't advise you to make a very small nick, because what happens is if you make a very small nick, you keep digging, and then you will make a nick on the baby's parts also. Instead of that, first you make a 5 centimeter and wipe out with one finger. Then you make 4 centimeters, wipe out. Then it slowly, all the layers will open up. Then 3 centimeters and 2 centimeters. So after making the nick, you put 2 fingers inside and use a scissor, and you go sharp. So these 2 fingers inside the uterus will guide you, one, and they'll protect the baby's parts. And you can go for a sharp dissection. And while going also, you should go curvilinear upwards and on both sides. But this sharp entry usually is needed if the lower segment is brittle in a scarred uterus, previously scarred uterus, or if it is unduly thick, or if you want to make a very big incision right in the beginning, maybe because you are dealing with a big baby, or you are dealing with a twin, conjoined twins. That's what I did when I had to deliver the triplets, where one of them was conjoined twins, or if there is any coming in the way of the incision. So these are the situations where you have to do a sharp entry. Otherwise, if it is a supple uterus, as in case of primigravida or even multigravida without any previous scars, so there, after making that small nick, you put your 2 index fingers and you just steer them upwards. So that would prevent the bleeding. Even if you go a little bit extra, your fingers are not sharp, you see. So you will be pushing away the uterine arteries rather than cut the uterine arteries. So that is why it is always preferred. And when we are standing on one side, so you'll be able to do it. So you must have seen this. This is the most commonly used entry actually. Only in a scarred uterus or a previously brittle uterus, or if there are adhesions, then you will go for a sharp entry. And the third one is like an auto suture technique. You must have seen in laparoscopic hysterectomies, nowadays the clamps come. When the clamps come on both sides, there used to be auto. Nowadays, of course, we are not using those things. We have got better, uh, ultrasonic scalpels and things like that, which will automatically switch us, even seal the things. Otherwise, we used to have both sides clamped, and then you can cut in the center. So it will make an auto switcher. I have never used auto switcher in my life. I have only seen it in the videos, or I have heard about them advantages and disadvantages. So let us now critically analyze. I have already analyzed critically as I was talking, but now let us look at the evidence. So whenever I put this green, box, that means the evidence is coming up, and you are not able to see the Cochrane logo, which is behind my picture in picture. So this is a Cochrane review again about the uterine incision. Lower transverse has the following advantages, which I've already talked about. Less vascular, hence less bleeding, lower segment, whereas upper segment, all the vessels will be there and it is very broad and very thick. It is easier to repair and better approximation. Upper segment is so thick, that's why approximation will be very difficult, whereas lower segment is very nice and approximation is better, unless you are doing a very late second stage Caesarean section where everything is thinned out, so the approximation may not be very good. It has got better healing because the lower segment is a quieter segment or inactive segment during the healing period, that is in the post-natal period. So the healing is better. So that is exactly why. And the forces in the next pregnancy are not perpendicular to the incision, they are parallel to the incision. So if the incision is like this and the scar is like this, the uterus, when it stretches, it is literally pulling the scar. So that's why the rupture will be more in upper segment, rupture is less in lower segment. So lower incidence of uterine dehiscence or rupture in the subsequent pregnancy. So obviously, that is the reason why all of us now are going for the lower uterine segment Caesarean section. What are the uses of other incisions, which I've already told you? Lower vertical probably is for a preterm baby, but I have never used it. Classical is not totally obsolete or out of the modern obstetrics. It is coming back in a way, I should say, when the lower segment is poorly developed or not approachable because of the thick adhesions. In another talk of mine about Caesarean section, the troubleshooting in Caesarean sections, I have talked about fundal incision, not just the upper segment, but a fundal incision, because not only the lower segment, the entire anterior wall was not approachable because of the dense adhesions with the intestines and other things. The surgeon came and did their best, but still the anterior uterine wall was not approachable. So I have done this fundal incision twice in my life, twice or thrice in my life, once in St. John's when I was the senior house officer, and twice in Manipal and Udupi. So other reason is elective Caesarean hysterectomy for placenta percreta. As I already told you, when there is percreta and the whole of the lower segment is occupied by placenta, no need to disturb that. Go for upper segment Caesarean section, quickly deliver the baby. No need to remove the placenta, just put the towel clips and go ahead with the hysterectomy. Intrauterine manipulations is anticipated. Suppose it's a breach, or if the back is down of the transverse lie. It's very difficult. See, if the transverse lie back is superior, we can put the hand inside, catch hold of the feet of the baby. I always tell it's easier to pull somebody else's leg, isn't it? So catch hold of the feet of the baby and do the internal podalic version breech extraction. But if the back is inferior, back down, then it is very difficult to go. So you have to really put your hand inside to deliver the baby. So that is where classical section becomes handy. Lower segment is distorted, or it has become very big because of a large myoma. You don't feel like putting incision anywhere there for the fear of huge bleeding. So you go avoid that area and go for the upper segment. or delivering of a large baby or an anomalous fetus. Of course, nowadays we can still deliver even a conjoined twins, as I told you, I delivered through a lower incision only. But suppose you feel it is very big baby, or if there is a big problem, sacrocartilaginous tumors and things like that, you can go for an upper segment. And then J-shaped or T-shaped, as I told you, to obtain better access or facilitate delivery of the infant. These are all desperate incisions. You have put a transverse incision and suddenly you realize at the time of delivery of the baby, it is not possible. So you go for a J-shaped first, but sometimes you don't know where exactly put the incision. Desperately, wherever is possible, you put, and after the delivery of the baby, you realize you have put a inverted T-shaped incision. So occurrence of rupture of uterus, classical is 4 to 9%. It is very, very high. Inverted T is as bad. In fact, according to me, it is worse. Again, that is 4 to 9%. Lower vertical is not bad. I mean, not any better. It is 7%. So because usually it goes to upper segment. And then finally, lower transverse is 0.2 to 1.5%. That's exactly why lower transverse is always preferred. It is less than 2%. ACOG recommendation is limit VBAC, that is vaginal birth after cesarean, to women with lower transverse only. Don't venture VBAC with classical T-shaped or lower vertical. That's why it's important to see the notes of the previous Caesarean section, and especially if it is done in your hospital. So now let me compare sharp versus blunt entry. Sharp entry, as I've already told you, better exposure, whereas blunt entry is limited exposure. You can't really make it big. And suitable for scarred uterus. As a brittle uterus, you can't really tear. Supple uterus is better. Primigravida is better. And it's a rapid delivery because sharp entry, there is no need to any further, and you can just deliver. Whereas it's a difficult delivery because your tearing may not be sufficient enough. You put your hand, then you realize you have not made an incision bigger enough. Then you have to go again and convert it into sharp entry or whatever. Then easier to repair. Sharp wounds are always, clean-cut wounds are always easier to approximate and repair. Whereas when you tear, you don't know, it will be ragged. Sometimes our different layers are coming up. It's not easy to repair. Then there is inadvertent injury. That's the disadvantage of sharp. If you overshoot in a hurry, you'll be cutting the uterine artery. Whereas here, it's not possible to cut the uterine artery. So what does the evidence say? Blunt dissection was associated with a reduction in mean blood loss at the time of procedure, which we already understand, and no statistically significant difference related to need of blood transfusion with the blunt entry. I think I will stop after this slide. Auto suturing technique has got some advantage in homeostasis, mainly used in HIV, but Riker has not used this at all, as I already told you. So tomorrow I will come up with part 2. Happy